I'm Armin Brott, and talking with Dr. Wizdom Powell, and I want to let you introduce yourself because there's so much to introduce.
Sure. I am the director of the UConn Health Disparities Institute, and I'm an associate professor of psychiatry at UConn Health, and an advocate for men's health and the health of boys and men of color in particular.
A really terrific advocate. And we were just talking a few minutes ago about how we've both been dealing with this issue about talking about how men have shorter, sicker lives. And generally speaking, nobody wants to hear about that. It just doesn't get the kind of change. And so from different angles, we've come at this and decided, okay, you know what, let's talk about how much this costs us. And we did a paper dealing with that, but you did in your talk, you were talking about that. I'd like to have you start talking about the issues and how much it costs us as a society in payments and lost productivity and all that.
Yeah, I mean, I think you open up an important, portal to discuss some of the additional costs, because we talk about, as you mentioned, the health consequences and the family system consequences when men die. Before their time, women and children are affected, and we've had that conversation.
Tax revenues go down, and in those payments out to widows and survivors go up, and
Absolutely.
which are unnecessary or could be reduced anyway.
Right, and I think the very real thing that we know is that it's having a direct impact on health costs. I mean, and health expenditures for our nation. Whenever there are huge disparities for particular populations, we see exacerbated excess medical cost. There are direct costs to the workforce and indirect costs to our capacity to compete in the global marketplace, because there is a loss of economic productivity when men are not in the labor force. And we're seeing a consistent decline over time in the number of men who are in the labor force, which I think is pretty significant and important to discuss, and that we're not talking about, and that a lot of that labor force drop off, at least some of the researchers who are working in this area seem to assume that it can be attributed to behavioral health disparities or issues with opioid substance use. And I think,
well, to talk about that one in particular, I mean, I just remember the graph that you had up there, which I'm looking at that thinking that can't be possible, that the number of men are actually declining. And that you said the more shocking thing of all, I think you said half of men aren't in the workforce because of opioids.
yeah. And what's even more significant about that finding was that it's at the particular time in a man's life when he's in his prime. So it's midlife, we're seeing this drop off. And so you can't help but wonder over time what the implications will be for family wealth, accumulation. And we have so, many discussions in this country about wealth inequality and wealth gaps. And here we have a clear, sign of why those gaps might be produced. And I would imagine if you were to slice that data by race, ethnicity, you would see by subpopulation probably even more pronounced economic, impacts.
Just wondering about that because you deal a lot with African-American men and boys, and I think the media tends to pitch the opioid crisis as something that is not affecting African-Americans as much as it is non-African Americans. What do you have to say about that?
Well, I don't, deny that the issue is affecting men writ large as a population, but we've also seen that there are significant death rates within African American and Hispanic men that are comparable to the opioid deaths that are related to substance use. And we're not really having that conversation. In fact, the common public discourse around this, or this tension in the public discourse, has been that the media and all of our attention has been focused on the impact of the opioid crisis when we had a significant crack epidemic in the 1980s,
Right.
and significant, heroin epidemic at different times in our history, and some would say a resurgence of that within brown and black communities, and yet that hasn't really been given a lot of airtime. And I think that kind of conversation needs to happen, and a lot more airing out of the actual data and sliced by or disaggregated by race ethnicity, so that we can see if there are particular populations who are in fact at greater risk.
Well, I think some of it has to do with the difference between, or at least the way that it's being pitched media-wise, between street drugs and prescription drugs. And because African Americans tend to be less likely to be insured, they're less likely to get a prescription for something, right?
Have access to those, right?
Right. So
As often, and that kind of sort of split in the population or split in the dialogue, so to speak, also is problematic, right? You can, all over that are like an undertone of issues around bias that we can, could spend this whole interview talking about, sort of, why are we, like, those are prescription drugs versus street drugs, and how people think about that. But that is, in fact, I mean, you're pointing out something very real. That is exactly how the conversation is going in our country. Right. And I would say that it's not helping us, because really this is all of our issue. Because as we look at our nation, and this is for some an uncomfortable truth, but we are undergoing one of our most significant demographic transitions, where our nation, our workforce, will be largely comprised of people of color. I mean, our nation will be. I mean, it's just the way we're moving, and it's not. I think it's an opportunity for us to have a different kind of conversation, but it's also something we need to pay attention to if we, in fact, think we don't have to think about those people.
So. We need to have a conversation, obviously, not just one. We need to have a whole bunch of them. But what I really want you to see if we can get to this is, what do we need to do about this? Because just talking about it, that's the frustrating thing. I mean, I've been coming to conferences like this, and so have you, for many, many years, and there's talk, and we keep hearing the same data points about the influence of fathers and men's health, and you just want to say, okay, what are we going to do? I mean, how do we do something about this?
I mean, the good thing is that we have some policy opportunities, right? I mean, I think, Senator Kennedy used to talk about policy windows opening and closing, and how critical it was that when it opens, you'd be ready to move through it. And I think right now, even as health reform is, complicated, and there's always the threat of the ACA being, repealed is always around, I think within the ACA, we saw, for example, one of the most significant upticks in insurance rates among childless men that we'd ever seen in our, for a long time. And that was because Medicaid expansion allowed a lot of men to come onto the insurance rolls. And the exchanges opened up opportunity for men who may not have been insured before to get insurance. Now, insurance doesn't equal access. There are all kinds of barriers for people to actually go in to get care. But it does remove a significant financial barrier. Right. And it does create an opportunity for men to get into primary care. And if you have a primary care medical home where you also integrate behavioral health care, then you have also an opportunity to reach more men. So there are a lot of states that are taking up these issues in their state innovation model programs. Like, there were many states that got grants from the Centers of Medicaid and Medicare Services. And through those programs, they're building clinical community integration programs where we're really starting to have a conversation about how do we build more holistic care so that people can get connected directly from health care to the community services they need. That gives you a bigger opportunity to address some of the social determinants of health we're talking about: economic employment, economic capacity, right. Employment, labor force participation, that kind of thing.
Could you talk just for a little bit, since we're on disparities, and I mentioned this when I was introducing you, that we did a paper a little while ago, just within the past couple of months actually, about ACA and about the difference between the services that are provided to men and boys versus the ones that are provided to women and girls. Well, women visits are covered, but not for men and boys, which, yes, you have access to a primary care physician, but you might have to pay the copay for that. And that could be the difference between getting it, or STD prevention and screenings and mental health, which I want to talk to you about separately.
Well, I mean, our healthcare system, primary care in particular, wasn't designed with boys in mind. I mean, and even the girl visits are all in place because of particular reproductive changes that women go through that necessitate their engagement with healthcare early in the life course. We don't have that kind of lever for boys that's biologically driven, right? So either you play for like a school sports team and you get to healthcare because you need a physical to play on a football team. That might be how you get introduced to the healthcare system. But other than that, there's not really a whole bunch of guidance, and there are not a lot of opportunities for boys to get socialized around healthcare. Right. And we have to change that. I think that's part of the challenge, because you can start to have the conversations and talking to boys about the importance of preventive care, but they don't have an avenue to get that, a reason to go. then that's going to be a problem. So we have to align ourselves both on the policy side, but also on the clinical care side. So the recommendations clinicians are making include, this very important population. Yeah.
Dr. Wizdom Powell, thank you so much.